OCT for the general ophthalmologist. I think the term general is not really correct. We should call it comprehensive, because most of the general ophthalmologists deal with cornea, glaucoma, a few retina cases also. So I think the topic correctly should be for the comprehensive ophthalmologist. And I hope that we all stick to the time and we have a interactive session. The first speaker is Professor Major General Mrs. Sagarika Patial, and she'll be speaking on OCT in glaucoma patients.
Good morning, and welcome to the people who have come to hear us. And I'm going to make OCT as the way I understand it and the way I put it to clinical practice. So this is, as he said, it's basically for a comprehensive ophthalmologist. The first question that arises in our mind is, why do we need an OCT? Why should I do an OCT for glaucoma diagnosis? We all know that the ganglion cell complex is the first part of the structural part to be affected in glaucoma. Now, mind you, it is the OCT which detects that and keeps us alert. It is not that we're going to treat the patient, but the moment we see, okay, there's one structural damage which has occurred in the ganglion cell complex, we immediately, our antenna are raised. Patients who cannot perform fields, so many of us find patients like that. Then how do we record damage? How do we record that there is progression? That is only by means of OCT. So basically, it is used to create a foundation for our diagnosis of glaucoma, progression of glaucoma. So it provides an objective, quantitative, accurate, precise, reproducible measurements of three structures which are extremely important to us in glaucoma diagnosis. That is the optic nerve head, the retinal nerve fiber layer, the macular substructure. Now, there is software that is so important for us. Software which can be used to measure change over time. That means progression can be noted to detect whether there has been a progression in the disease. So we also therefore have a statistical data which is available, a software which is available, which determines whether the structural features of optic nerve head, RNFL of a given individual, whether it falls within the normal range, or there is statistically significant difference that has occurred over time. The most important thing I feel whenever anyone is buying any OCT is check what is the normative data. So in the OCT which we are using and which I'm going to describe in detail to you all, it is the RTVU. This was the first OCT which had come up in the United States, and it's used extensively in India too. It has a very good database, clinical data of approximately 10 clinical sites worldwide. So there were 555 eyes which were enrolled in the study. Mean age group was 49.5. Range was between 18 to 82. Now, mind you, this becomes a huge problem because children who are below 18, and many of them are coming to us now for detection whether they have glaucoma or not, we have no database. But we can always record it and then follow them up over time. Ethnicities have been Asian, Hispanic, Caucasian, and African American. Now, what does the RTU scan? The optic nerve head, the ganglion cell complex. It also gives us the macular scan to tell us about what has happened to the ganglion cell complex. The first thing we must determine is what are the tips for obtaining a good OCT. So for that, first choose the right scan protocol. Remember that if you choose a fast protocol, it minimizes motion defects. Adjust the scan position. That means the patient should be sitting properly. The scan's ring should be absolutely around the optic nerve head. Check the signal strength. And if it is, I will talk about this, in case you find that the patient has got a dry eye, please put in artificial tears. Ask the patient to blink properly, but do not blink during the testing. Check if there are black areas in your scan. That means there's missing data. Please have a look at the signal profile analysis, the RNFL thickness quadrants, sectors, everything should be checked. Please check correlation with the visual field. And most important, have a look at the clinical data and involve the patient. Tell the patient, look here, as this is very good. Explain everything to the patient too. Please do consider the cost. Do not do it for a patient who does not require it. Do not do it at 6 monthly intervals. Makes no sense. Do not rely on the colors. I've seen green, I've seen yellow, and therefore this is all right. No, that's not the correct thing. Please look at the numbers. Clinical examination is an absolute must. Also remember that it is not just the RNFL which you have to look at in glaucoma diagnosis. Please have a look at all the things. All the information is there for you. Please take in all that information. That means whether it is GCIPL, whether it is the circumpapillary RNFL, please have a look at the optic nerve head. So all the tissues which have been affected by glaucoma should be taken into the OCT, into your consideration. So as we get set, go for the glaucoma diagnosis, look at the signal strength, motion artifact. Have we acquired a proper image, and also access raw data? Be like your retina colleagues. Please go and have a look at the OCT, whether it is correct or not. So the first part of the information in the printout is age. Very, very important, because it is comparative. Explain to the patient, you must give your age, because it is being correlated with the normative data. Examination age, date of birth, as I've said already, and patient's registration number. Now, first important thing is quality of scan. Now look at, this is the RTVU scan. Now I have marked in a please can I have a pointer? So you can see that there is a yellow color, a red colored mark out here. And this is the signal strength. At the bottom I've written there's 41, and as per this it is 25. Now remember that if you look at the first scan, that is this one. This is the scan of the GCC. Now that is the ganglion cell, macula. In this, you find that it is only 41. Why is it 41? Because the patient is looking straight on. Therefore, you get a very good image. On the other hand, when you're looking at the optic nerve head, what do you tell the patient? Look a little on the side. So when you're looking at the side, at that time, the iris comes into view, and therefore, automatically your signal strength decreases. Now, this is the signal strength in all the types of printouts is not the same. This is of the Cirrus OCT. So whereas in the case of OptiView, it is the manufacturer has said 40 is the signal strength that we should take into consideration. In the case of Cirrus, it is 7. Now where is the 7? You have to hunt for it. It's right at the top. Just look at this at the top over here. So please hunt for that. Before you look at the printout, look at the signal strength. Now we come to spectralis OCT. In this, it is the signal noise ratio. Now this is of 15 decibels. Now this is again, where is it present? Again, it is present at the top. So we find that this is something that you all must look at before we go on to the actual examination of the OCT. So if you find your image quality is unreliable, subpar, inaccurate data acquisition is there, it confounds the image interpretation. So if you've got a very, very weak image or a soft image, then in that case, the software is unable to accurately identify the boundaries of the layers being able to measure, it is wanting to measure. So therefore, you will get it leads to an improper clinical diagnosis and decision making. Therefore, reduced scan quality reduces tissue thickness. I will show you one example. Simple methods. First of all, make the patient understand the test, blink before the test, instill artificial tears. Remember that every eye has typical microsaccades per second. So unless you have image tracking, motion artifact will be very likely even with the most cooperative patient. So accurate acquisition of image without cutoff at the image edges. I will show you examples with good centration of the optic nerve and the fovea is very important. Now this was a young girl around 15 years old being followed up as a glaucoma suspect. Now look at the scan which we have taken. This is the first scan. And with the first scan, we found that suddenly, oh my, it is 41.8. So can I continue? I've got a little left. Yeah? So 41.8 is too less. We repeated it and we found that, okay, it's become absolutely fine. Again, the GCC shows the same thing. So now you look at the way the scan is being placed over here. See, this is improper. It's a 3.4 millimeter diameter, but it is not properly placed. You have to look at the termination of the optic nerve border. Look at the segmentation. And then after that, have a look at the hourglass pattern that comes over here. And you can first of all only see that the red and yellow is telling us that yes, the nerve fiber layer is very good. Again, you must know that there are 12 radial lines which are being taken, and the NRR thickness is being measured. And don't look at the red and yellow, but please have a look at the numbers. Now look at this one and look at this one. Hourglass pattern, all the numbers are present sector-wise, and you can come to know. Remember that the RNFL thickness does change with age. Normal it is 95.4 approximately. In Indians it's 100. Early glaucoma it becomes 80, advanced glaucoma 70. There is definitely an RNFL decay with age. You must look at every sector. Don't just go by the entire quadrant, because you will miss certain factors. And you must not forget this entire chart that I've given over here. Area of the disc is extremely important. Cup and rim is very important. Average retinal nerve fiber layer thickness is very, very important. So early defects, one small car can be missed. Therefore, you must have a look at all the figures. And the parameters which are extremely important for glaucoma diagnosis: vertical rim thickness. Please look at these figures, very important. Rim area, vertical cup disc ratio, and in the GCA, the inferotemporal sector average, superotemporal sector average, and the inferior sector ganglion cell complex. Extremely important figures that you must not miss. Therefore, I go back to it. So area of the disc is extremely important, cup and rim. And now we come down to RNFL thickness map. So now the two of them are placed in the normative data, and you find that one is a big line which is telling us, okay, it's present in the normative data, whereas the blue line is definitely below. Therefore, there is a definite difference. Remember, asymmetry is the hallmark of glaucoma, and this itself is telling us asymmetry is definitely present. And this, the ganglion cell complex, as we know that whenever you do a ganglion cell complex, don't forget to look at the macula. There may be concomitant macular disease. You can have macular edema, you can have epiretinal membranes and ARMD. Then you'll get fooled. So once you do it, you find that first of all is the thickness map. This is the RTVO map. And then after that, how much is the deviation? All the ones that you can see in black is how much it is deviated from normal. What is the statistical significance? And you find the whole thing is in red, highly statistically significant. Therefore, remember, in the RTVU, we have one figure which is very important, the FLV. That is, if your FLV, the focal loss variance, is a very important figure which tells us whether the patient has glaucoma or not. Now, I'm asking you all, should this figure be repeated? Please have a look at the signal strength. Very, very poor signal strength. Have a look at this matter over here. See, there is loss of data. And if there is loss of data, remember it's going to be extrapolated. Remove this, please repeat it again. Now, this is the way we always do of the glaucoma change analysis or progression. And in this, it does, if there is progression, is if there's 10% loss is significant, if it is confirmed on the second visit. This is, mind you, of the RNFL. GCC, similarly, if you find that there is a loss, see, you can see the loss out here beautifully. So we have already taken a good OCT. I'll just give you one example. I've got plenty, but I will give you one example. 53-year-old male, high myopia, no other risk factors, CCT normal. You find that the right eye has a huge defect. And then if you look at the OCT, we find that what is important for you to understand is that the optic disc area is extremely low. See, it is 1.12. Now, you all know that Indian eyes varies from about approximately 1.5 to approximately 3.3. But here it is very low. Look at the rim areas. So this is going to give you an indication that, yes, this man has glaucoma. 19-year-old male, referred for glaucoma opinion. Just have a look at the retinal nerve fiber layout here. Also look at the optic cup. Everything is absolutely normal. But he has a small defect in the right eye in the visual field. If you look at the defect also in the GCC, in the retinal nerve fiber layer here is the defect, and also in the GCC. Is it glaucoma? No, he had an optic disc pit. 51-year-old male, he was on metoprolol. If a patient is on metoprolol, remember his intraocular pressures may be absolutely normal. He had open angles, his IOPs were normal. He had a huge, almost like a hemifield defect. And when we did his OCT, we find that there is a huge defect in the RNFL as well as in the GCC, signifying that, yes, and of course the huge amount of asymmetry, signifying that the patient has properly glaucoma. 81-year-old male, hypertensive, diabetic, bilateral, pseudophakic, on lots of medicines with, again, we find that this patient definitely has. Please do not forget to look at the SSIs, the signal strengths. There's asymmetry, left decreased, superior and inferior, RNFL decreased. And please remember, the FLV, although should be able to tell us whether this patient has glaucoma or not, it is only borderline. So the entire OCT has to be taken into consideration with what the findings are. Now, I will go on to the last one, which is very, very important. 43-year-old lady, diabetic, hypertensive, bilateral aphakic, pathological myopia. Please have a look at the fundi, and you find that there are a huge amount of pathological myopia out here. Remember, high myopics is not added in the database of patients. Therefore, you cannot, the software is inadequate. It cannot. Also very important is, please have a look at this figure. See, there is missing data out here. So it's going to be extrapolated. There's missing data out here. It's going to be extrapolated. Therefore, in myopes, you have to be very careful, and OCT is not going to be greatly helpful. Again, the same things I've shown, and that's about it. Thank you very much. Yeah, I'm sorry I've taken so much of time, but there was so much of information. Thank you so much. Any questions, please let me know.
Just a couple of questions. Yeah.
Any questions? Thank you.
Can I slides, please? Thank you. Hi, good morning. I'm Dr. Raghav Malik. Thank you to all my co-instructors for this opportunity. Today, I'll be speaking about the anterior segment optical coherence tomography for the anterior segment surgeon, and what all we can learn from this scan and how it can help us in diagnosing, managing, and also for therapeutic treatments. So what is an OCT? OCT is a non-contact, non-invasive diagnostic technique that permits high-resolution cross-sectional imaging of biological tissue using light. So OCT uses near-infrared, low-coherence light to achieve a resolution of as between 5 to 20 microns. Lower the resolution, better the imaging we get. So this is a normal cornea as seen on the ASOCT. If you can see, we can see all the layers. We can't see the sixth layer, the pre-descemes layer, but yes, we can see the tear film. We can see the epithelium, whether we have any irregularities in the epithelium, any breaks. We can see a very clearly delineated Bowman's membrane. This is the Bowman's, the white membrane between the epithelium and the stroma. Then we have, of course, stroma that makes about 85 to 90% of the cornea, and then the descemes and the endothelium. So this is just a normal anatomy of the cornea, and there is so much more we can understand, which I will show you in my subsequent slides. The tear film, epithelium, the white Bowman's membrane, the stroma, and the descemes. Now, the clinical applications of ASOCT in cornea and refractive surgery. To assess the corneal thickness, which is very important, it is done in all our pre-operative assessments for refractive surgery to evaluate the pre-surgical and post-surgical corneal anatomy. Guided laser-assisted cataract and refractive surgery to image the intracorneal ring segments to see where they are placed, their thickness and the thickness of the cornea below and above them, and to see the position and vault and the sizes of phakic IOLs. For keratoconus, yes, it is a very important modality to help us show the thickness where the cornea is thin, where it is thick, and also very importantly the thickness of the epithelium layer. That is also coming up now. If there is an inferior superior or in IT and superior octant difference of less than 45 microns is very important for diagnosis. I won't go into details, but yes, this is a scan of the cornea. You can see this patient already has a thin cornea, but yes, if you see the epithelial map, we can see the thinnest point is here. So there are very important signs we can get from this scan. One is, yes, that there is thinning of the cornea. Secondly, the thinning is displaced inferiorly. You see the Y coordinate minus 937. So it is about 937 microns away from the center of the corneal apex. This shows, yes, there is thinning inferiorly, which is a very important clinical sign for early ectasia. So such a patient will always be excluded from surgery and will be followed up. This is an epithelial scan showing thickness of, this is an ASOCT based thickness map. So we can see areas of reddening where it is thick and area of blues, that is a cold color showing thinning. So inferior thinning corresponds to the thinnest cornea, and in case after surgery we see, so the earliest signs of ectasia are thickening, localized thickening of epithelium. So if in areas we see that epithelium is being is seen in a localized area, it is hypertrophic. That means there is an early sign of ectasia, and such a patient should always be followed up. So this is a case. This is an inbuilt microscopic ASOCT showing an acute hydrops of a 28-year-old girl who came to us with sudden diminution of vision up to finger counting and half meter. I'll show you a video how we manage this. You can see there is a break in the DM over here, and yes, look at the fluid pockets inside the cornea. So the cornea here is very thin. It is, look at the stroma, which is almost I would say scarred, and yes, there is thickening. We can also use the AIOC to see a post C3R demarcation line. You can see this line, this shows the demarcation. So it's very important to differentiate a post C3R and a post PRK demarcation line. This gives us a good idea whether a C3R has worked or not. Like I also mentioned, to measure the depth of intacs, this is an AIOC showing intacs within the corneal stroma. It also allows us better visualization of LASIK flaps. You can see a very well delineated LASIK flap, the thickness of the flap and the thickness of the cornea. This was a case that came to us with an inferior corneal opacity. You can see the clinical picture. There is an opacity here. So before surgery, we had to determine whether we can go in for a femto LASIK or not, because a femto laser does not pass through a thick opacity. So pre-operatively, if you look at the AIOC, we can see that the starting earliest point of the opacity is at about 217 micron, and our flap will be at 110 micron, so we are pretty safe. So we went ahead and did the surgery, and you can see post-surgery also, our flap is much above the 217 area. So it helps us, it's like a diagnostic modality telling us when we can or cannot do a surgery. It can also help us making a decision whether you want to lift a flap after a corneal surgery. So it shows us the flap and different areas where there are opacities. If there is enough bed, we can lift the flap. Otherwise, we can go in for a surface ablation. We can also use the AIOC to see the post-DSEC graft. You can see the thickness of the cornea has increased post the DSEC, and this is a 160 micron DSEC graft. Post-op DM detachment, yes, this is a case that came to us from elsewhere, operated elsewhere. The patient had vision 612, not improving after a month after surgery, and you can see a very well demarcated DM detachment. I'll show you a video showing how we did manage this case. So we can use this also to surgically manage our femto cataracts. So we've done extensive work on posterior polar cataracts. We can see that this patient, if you see the inbuilt OCT in the catalyst system, you can see that in the posterior pole, there is an area of discontinuity showing that on table, this patient is likely to have a posterior capsular rupture. We have also published this. You can see this is the same patient having a typical posterior polar cataract. On the slit lamp, you can see a very well equator to equator PCR. And on the microscopic OCT, we can see a disruption of the posterior capsule. Similarly, on the IOL master also has an AIOC showing a disruption of the posterior capsule, and the bottom right image showing the femto laser. And this is a very important image. The bottom left, you can see with an intraoperative microscope, you can see that the posterior capsule is ruptured and there is a vitreous blob that is protruding inside the bag, but it has not been broken. So we can go in and put in a lens inside the bag also. So using the femto laser, we have also published showing that yes, a femto laser helps us in increasing the safety in posterior polar cataract. So if on the AIOC in the femto laser, you do see there is a disruption in the posterior pole, there is a 75% chance that on table, yes, you will have a disruption. But if on the catalyst AIOC, you see that the posterior capsule is intact, there is a 100% chance, yes, that on table it will be fine. So very important study, a landmark study, and we are doing much more work on this. We can also use the AIOC to see the volt after ICL. You see this is an 859 volt. Our normal volt should be between 400 to 750 micron. Anything less than 300 or more than 800 should always make us worry that yes, we have a thin or a less or a higher volt. Now I'm going to show you a very good collection of videos using the intraoperative AIOC microscope. So this is a case that the same decimator, the patient who came to us from after being operated elsewhere, the patient had a DM detachment. You can see it's a very big detachment, a bullous detachment. On the microscopic integrated OCT, there is a DM detachment. We go in from the side port, we make a side port, and 14% SF6 is put inside the cornea, and you can see immediately, you can see that the DM is attached. Look at the bottom right image. You'll see the DM is now attached. So immediately you know yes that the patient has a DM attachment, and patient is made to lie for about 10 minutes, and next day the patient's cornea is clear, vision is 6/9, and at 1 week it is 6/6. This is a day 10 post-op. Now this is another case, the same case, who had the acute corneal hydrops. You can see there is, look at the cornea, it is so white, almost scarred. Patient came to us a week after a decrease in vision. Again, we go and do a desmetopexy, and immediately we can see the desmes attached. Make the patient lie down for 10 minutes, and yes, the patient, lo and behold, on one day, the cornea has cleared up. Like at 1 week, the cornea is, the opacity is gone. So doing this is very, very important. Again, for patients, for people who are learning to do SMILE, we can use the AIOCT to learn how to find the planes in SMILE. So look at this patient. After you find the initial planes, you can use a dissector, and look at this. This is the mushroom sign which we have described. Our dissector is right now just on the inferior plane. There is a lenticule and then we have a dissector. So we are in the wrong plane because we always dissect the anterior plane first. So now again, we have to now shift gears and go into the anterior plane, search for it. And now you see, this is the anterior plane, there is a dissector and the lenticule is between the dissector. So now we go ahead and we remove the lenticule. This is one of my last videos showing how in a posterior polar cataract we can save our posterior pole. So this is the same patient who had the posterior capsular rent before surgery. On table, what we do is the most important part, that we have the ability to increase the offset of the posterior capsule. So what we are essentially doing is that we are increasing the posterior offset, so the laser is firing at 1000 micron distance from the posterior capsule. So the pneumo dissection, that is the air bubbles that are formed, are from about 1000 microns from the posterior capsule. So our posterior capsule is saved from intraocular turbulences during phacoemulsification. So once this is done, this is our intraop OCT. It shows very well that there is a discontinuity on the posterior capsule. So we go ahead, look at this, how beautifully we can see that the posterior capsule is damaged. We do our surgery. Once the cataract is removed, what I want to show you is this. So what we've done is, because of that 1000 micron offset, we have essentially created a new posterior capsule. So that 1000 micron epinucleus is saving our nucleus from going down, and that is holding all the turbulence. So this, though there is a discontinuity, we could do a phacoemulsification very well. The nucleus was removed and we do a very soft and smooth cortical aspiration now. So you look at the discontinuity, we remove the cortical matter very smoothly, though we know there is a posterior dehiscence. But what we achieved with this is that, of course, we were warned prior to the surgery. And secondly, like I said, the vitreous is not disturbed. So we don't require any vitrectomy. We go in and put in a 3-piece lens in the sulcus in this case. Patient did very well. He was 6'6" on the first day. So to summarize, AIOCT is essential to not only to diagnose, but also to manage corneal and anterior segment cases. It helps in detecting findings and structures that may help us in routine investigations. And the microscopic mounted AIOCT is an additional tool that extends benefits to the surgeon. It's an essential tool in the surgeon's armamentarium, thus making it not just a diagnostic tool, but also therapeutic. Thank you.
Excellent talk, Dr. Raghav.
Thank you, sir.
See, in retina,
Yes,
there are
sir.
some disease entities like myopic traction maculopathy,
Yes,
lamellar hole, pseudo hole, which we cannot diagnose without OCT.
Yes, sir.
Just for my information, is there any disease entity in cornea which you cannot diagnose without anti-segment OCT?
Definitely, sir. Like a desmes detachment, yes, because the cornea, it causes a very dense stromal edema. So because of that white to white limbus edema, you cannot see just desmes and where exactly the desmes had detached from. So just to plan a desmetopexy, where we want the direction of the air bubble to go to, we have to do an AIOCT. This is very, very important to show that where the air bubble has to go from, so that our desmes can reattach. Because if we do in the opposite direction, we'll have a folded desmes, and that will ultimately die off. So doing that within the first 10 to 12 days is very, very critical. So yes, this is one case where without AIOCT we cannot do it. So that is why we have referrals from other centers, because having an AIOCT, not every surgeon has it. So there are cases that come to us, to tertiary centers that have desmes detachment about a week prior. They come to us and within 2 days they respond.
Type of corneal surgeries, I think that also is.
Yes, DSEX, DMX. Most of our surgeries we now do under AIOCT guidance. It really helps. Of course, it's a very, it's I would say an academic tool, but yes, it really helps. So these cases that I showed you, of course, can be done without an AIOCT also, sir. Just that they give us immediate intraoperative confirmation.
Okay, any audience questions? Just
no, sir. SF6, 14% in desmetopexy. So giving air in such a case would not be helpful, because one, these cases are referred to as probably a week or 10 days after surgery. So the desmoid is also not the healthiest. There has been a detachment for about 10 days. So if we put air, the air would stay for maximum about 6 hours, 8 hours. And if we want that air bubble to stay, gas bubble to stay inside the AC and give us a proper attachment of that endothelium on desmoid complex, that's why we give an isoexpansile gas. That is why we have to dilute the gases. We can't give full, because if we give a full concentration of SS6 or C3F8, what will happen is that the air will expand and the patient can go into pupillary glaucoma.
Okay, thanks a lot.
Thank you.
So unfortunately, Dr. Dinesh Talwar could not make it for the meeting. So Dr. Purnima is going to speak on how to read a normal retinal OCT, and after that she will talk about pathological changes in the OCT in various retinal disorders.
Good morning, everyone. So I'll be talking about how to interpret a normal retinal OCT and what are the features that we can see. So OCT, we know we are able to get the different images because of the varying degrees of reflections from the different retinal layers. So whenever we are doing an OCT interpretation, we do two types of analysis. One is a qualitative analysis and one is a quantitative analysis. In the qualitative analysis, we do an overall study of the morphology of the layers, any changes, and we look at the reflectivity patterns. And in the quantitative analysis, we look at the thickness and volume of the layers. So these are some of the lines and the scans that are done. The line scan would show in a vertical and a horizontal meridian only, but then this may sometimes miss out some lesions which are not in those meridians. So the preferred ones are raster and radial. Raster has got a series of parallel lines of high resolution, and radial is 360 degree but centered at the fovea. So these are some of the fine, you can see, pathologies which are picked up by raster or radial but which may be missed otherwise. So how does a fovea look at? At a normal retinal scan, a fovea would appear as a depression like this. And we are able to see all the layers very clearly because the interior boundary, that is the RNFL layer, is highly reflective, and the posterior most layer, that is the RP, is also very highly reflective. So this is the various layers, just a correlation, various layers in the scan, and this is the histopathologic correlation. Now, many times you will see a colored image. So what do these colors represent? They are false colors, they are not true. So what do they represent? The layers with very high reflectivity, they will appear as orange or red. So this includes the RP layer, the RNFL layer. While the layers with medium reflectivity, they will appear in different shades of green, like the plexiform layer, the external limiting membrane, ISOS layer. And the layers with least reflectivity, they would appear shades of blue, like the nuclear layers, the ISOS, and vitreous, of course, there's no reflectivity, so it appears as black. Now, whenever we are evaluating OCT images, so we have to go, first of all, look at the quality of the scan, then the position of the scan, and then we carry out the assessment. In the quality, we have to first see, are we getting both the inner and the outer band? What about the signal-noise ratio, any shadowing effects, and any abnormal profiles? So first of all, in the quality, see the first picture, you are seeing two areas where you are not able to see the interior and posterior band. But this is not due to any pathology, but because of the shadowing effect of the thick membrane in front. And in the second picture, you will see, this pointer is not working well actually. It's very weak. Anyway, so second picture, you will see overall there's a more noise ratio. This is because of any media opacity like a cataract. Sometimes you may see certain things there, but which are not really true abnormalities, but just an artifact. So like in the first picture, you see a gap there, but that is due to a blink. And in the second, you are seeing some wavy structure, but that is due to the movement of the eye. So how do you differentiate from a actual pathology? So first of all, you always have to correlate clinically. And if you feel that it is not correlating, then you always repeat the scan. Next comes the position. So are we actually centered on the fovea? That is very important. So always look for the foveal depression. If it is not there, ask the patient to fix again. If there is low vision in that eye, fix with the other eye on an external fixation. Or otherwise, we can manually try and shift the scan. Sorry, this is just running ahead. Okay. It's running ahead. Can you please 1 minute? Can you just... yeah. Okay. So, it's... No, it's, I don't know, it's just running ahead in between. Okay. Thank you. Okay, sorry. So now coming to the actual assessment of the layers, we have divided into different regions: pre-retinal, epiretinal, intraretinal, subretinal, and sub-RP. So these are, again it's running off. So these are the regions, okay? So this is how you see them. And these are the terms that you will use to actually describe the changes in the various layers, like irregularity, depression, elevation, fragmentation. So coming to first region, that's a pre-retinal region. It's a vitreous. There's no reflectivity, so it is a black area. But sometimes you may see some abnormal hyperreflectivity patterns. Like in the first picture, you'll see two membranes there. And in the second picture, you are seeing a diffuse kind of hyperreflectivity, which would be due to any vitreous opacity like a hemorrhage or an exudate. Second comes the epiretinal area. This is the vitreous and retinal interface, which is very highly regular, smooth, and reflective. But at times, it may show irregularity. You can see in the second picture is highly irregular. These are some of the changes that you can see there. The first one, you see a membrane attaching. This is called vitreomacular adhesion. And if this membrane leads to traction, then it becomes VMT, vitreomacular traction. In the third picture, you're seeing the whole of retina is being lifted up because of the traction. And in the last, actually, this patient actually had an NVE very close to the fovea. So on the scan, it appeared like this, an alteration of the foveal contour. Now coming to the intraretinal changes. So in this, the main thing that we have to look at is the reflectivity patterns, hypo or hyperreflectivity. Then we look at the shadowing, thickening and thinning, and ultimately the integrity of the layers. In hyperreflectivity, usually we'll see black spaces, and it means fluid. But all black spaces won't be fluid. So if it is a diffuse pattern, then it is diffuse edema. Or you may get cystic spaces like this, so this is cystic edema. But like I said, all are not fluid. So like sometimes, again it is running off. So at times you may see hyperreflective spaces like this, but this is due to atrophy of the retinal cells. So how do you differentiate? You'll have to correlate clinically. Now coming to hyperreflectivity. So like here you see hyperreflective lesion here in the outer retina. Similarly here, hyperreflective lesion in the outer retina. Sometimes you may see very intensely hyperreflective lesions, and these will cause a shadowing effect. Then we come to the integrity of the retinal layers. Are they all present? So like in the first picture you see there's a complete loss of all the retinal layers in the center. And sometimes you may have a partial loss of retinal layers like this. Next comes the subretinal and sub-RP region. Here again the hyperreflectivity pattern is very important, and especially in relation to the RP layer. So if the fluid is above the RP layer, then it becomes a subretinal fluid. And if it is below the RP layer, then it becomes a pigment epithelial detachment. So this case has both subretinal as well as a BED fluid. Now RP layer is very important because in many cases that's the layer which is actually going to tell you what is the possible diagnosis. So I'm again emphasizing the terms that you're going to use to describe the changes. So these are some of the changes. You may see undulation, elevation, thickening, fragmentation. So this is what you're going to see. Okay. So just a brief example. Now here the patient has SRF as well as cystic edema. Another case, you have similar cystic edema, but look at the RP layer here and look at the RP layer here. So you see here it is undulated and irregular, showing that these two are not the same condition. Another example, you see subretinal fluid here, similar subretinal fluid here, but are they the same? No. See the RP layer here, there's a PED as well as undulated, indicating that these two are again of different etiology. Now here I would like, when we are focusing on this part, I would like to focus on the outer layer, the external limiting membrane and the ISOS junction. These are very important because the integrity of these layers indicates the visual prognosis. So wherever they are intact, you know you're going to have a good visual prognosis, but wherever there's a loss in the central foveal, subfoveal region, you know the prognosis is very poor. Drill is another terminology. Here, that was in the outer layers. Here, the disorganization is of inner retinal layers. So here you cannot differentiate. You can differentiate the layers here, you cannot differentiate here. Again, this is an important visual prognostication. It tells low visual outcome, even if the edema resolves. So this is a case example, edema has resolved, but because there is drill here, the vision has not improved. So coming to ultimately quantitative analysis, this gives an overall idea of the thickness and the volume of the layers, and this is how we keep mapping and following the response to treatment. So finally, you should know always your anatomy well, you should know which are the OCT features, do a systematic approach, and always correlate clinically. Thank you. The next. Unfortunately, Dr. Talwar, our chief coordinator, could not come here this time, so I will be presenting his presentation. Of course, he is an icon and I cannot even hope to attempt to fill his shoes, but I'll just do my best. So till now, I had described the changes which we can see in OCT in retinal diseases. Now we'll be talking of specific diseases and what all features we can see in the common diseases. So OCT we know for diagnosis, for treatment, for follow-up, and for prognostication. So one of the common AMD. So in AMD, dry type and exudative type. In the dry type, like I said, we will see these kind of undulated RP. And in more advanced cases, in geographic atrophy, you will see loss and disruption of the external limiting membrane, of the ISOS junction, and the outer plexiform and nuclear layer. In exudative type, 3 types are there. Type 1, which is the CNVM is under the RP. So here you will see a PED with some subretinal fluid. Type 2, where the NVE is, CNVM is above the RP. So here you are seeing the hyperreflective lesion in the outer retinal layers. And type 3, which is basically RAP lesion. So here you will see the lesion extending from the retina going into the choroid at times. So at times, not always, but at times you can see it very clearly. So OCT is very important in follow-up and seeing the outcome. So post the treatment in CNVM, usually as it regresses, we will have hypertrophy of RP and the scar formation. That's when we know that it has regressed. Occult CNVM, here we would get usually a picture like this with a PED with subretinal fluid, and once it is regressed, then we keep a patient on serial monitoring, and as and when we get a recurrence of fresh fluid, then we again treat. One term I would like here to mention is RPE rip. So at times when we have a very big bullous tense PED, there can be a rip of RP here, like you see your RP rip here, and patient will come with sudden vision loss, and usually it has a very poor visual outcome. At times you may see a change like this, outer retinal tubulations, which is a sign of severe degenerative changes. Now coming to another common entity, CSR. Here you will have subretinal fluid, but at times you may see a small PED, which is the site of actually the leak in the FA. In chronic CSR, similar you will have CSR, but as SRF, but you will also see these kind of this irregularity here. This is called the brush border sign. This is due to accumulation of waste products in the outer photoreceptor layer and the outer retinal layers. In chronic CSR, you may also see another finding, that is increased thickness of the choroidal layer. This is seen on a modality that is the EDI, enhanced depth imaging. Another entity, this is a dome-shaped maculopathy, which is usually seen in high myopia. In advanced cases, we may see subretinal fluid in this. Coming to PCV, which is again a variant of AMD. Now here we have very characteristic OCT features. You may have a double layer sign, and you may have this tomographic notch sign, which is tall PEDs. So like you can see here, tall peaked PEDs along with this double layer sign. Double layer sign is where you have undulated RP separated from underlying Brooks membrane. Otherwise, you would not see a separate Brooks membrane from the undulated RP. So this is a double layer sign along with the tall peak PED, is very characteristic of PCV. You can also have these kind of features. You can have multilobulated PEDs, or you can have a notch in PED resembling a M. Important differential diagnosis from AMD would be adult vitreoform degeneration. Here you would get a similar kind of lesion, but see on the OCT you get a uniform amorphous material sub-RP deposit. So this differentiates it from a PED. Juxtafoveal telangiectasia, another macular degeneration. You will get similar, these kind of hyporeflective spaces, but like I mentioned earlier, these are atrophic spaces and not really fluid per se. So just mentioning briefly OCT pictures in some common diseases, ERM causing blunting of the foveal contour. This is a full thickness macular hole. And here OCT is very useful in calculating the prognosis. So this is a whole form factor. So if the hole size is smaller, you have much better chance of closure and visual improvement. But if it is more, then larger, then the chances are less. Many times post-cataract surgery, you may be finding patient having blurring of vision and not getting good vision. So this is where OCT is very useful in finding out these kind of cystic spaces in the retina. So this is the cystoid macular edema, and OCT is very useful in monitoring the resolution of that with treatment. Now coming to OCT in retinal vascular disorders, occlusions, arterial occlusion and venous occlusion. In CRAO, you would, this is again a very specific pathognomonic sign, complete opacification of the inner retinal layers, not the outer retinal layers, only inner retinal layers. And this will resolve as the condition resolves. Coming to venous occlusion, in central retinal vein occlusion, you'll have central increased macular thickness with subretinal fluid and multiple cystic spaces, which of course resolves with treatment. In BRVO, you would have similar this kind of cystic edema, but also diffuse edema. But one very specific character is that it is only on one side of the fovea. So it does not cross a midline. So this is again pathognomonic of BRVO. So you see edema on one side of the fovea, you are sure that this is BRVO. Now coming to one of the very common conditions, diabetic macular edema. Again, OCT here, very, very important tool. There are some very important OCT biomarkers in diabetic maculopathy. So this you should know: drill, subretinal fluid, intraretinal cystic changes, ISOS junction integrity, and the hyperreflective retinal spots. Now coming to intraretinal cystic spaces, now these are classified based on size: small less than 100 microns and giant more than 200 microns. And large cysts usually have poor prognosis because they're in the outer nuclear layer and the late stage of DME, and they cause much more damage in the visual function. So this is the patient showing, so they don't respond that well to treatment, and even with steroids, they will show a partial resolution. Coming to SRF, now this usually in some studies it has been shown, like Restore and Write, that presence of SRF actually is an indicator of better visual gain in the long run. So this is just a patient showing a resolution of edema with treatment, anti-VEGF injections. Mentioning again drill here, the disorganization of the inner retinal layers. Presence of that in the center 1 millimeters, that is 1000 microns, and disorganization of more than 50% indicates a worse visual prognosis. But in the early stages, drill could be reversible, and in this case, drill is here mostly because of the pressure effect of a adjacent cystic space. So that's why early resolution and treatment of edema is very important, so that drill does not become chronic. There are some OCT biomarkers which indicate better visual outcome in DME. One is presence of SRF, absence of hyperreflective spots, and integrity of the ISOS layer. Hyperreflective spots, these are usually a sign of inflammation. Higher the number, we know we are going to have early recurrence of DME, and they may respond a little better to corticosteroid implants rather than anti-VEGF. So this is just example of a patient where with reflective spots where it has not, responded a little with the treatment. Again, just an illustration, this patient has intact ISOS junction, so we expect a better visual gain. Here the ISOS junction is disrupted, so we know that the visual gain is not going to be good. Finally, the overall thickness map, which helps us in monitoring the progression of disease. One more, just sometimes you may see these kind of bridging retinal processes, and these are actually residual neural elements connecting the inner and the outer retina, and they show improved visual acuity after treatment. So that's it. Just briefly, we have given some features of common retinal diseases. Thank you.
Thanks, Dr. Purnima. See, cataract is just not just removing the cataractous lens. It has become cataract refractive surgery, and we all are using premium IOLs. So it is very essential, and the patient also is right in demanding good vision, not good vision, spectacle-free vision. So if the OCT facility is there, it's better that all cataract patients undergo OCT. There's a whole bunch of diagnoses that can be missed if OCT is not done. You may not read that, but at least if you get the OCT done and you can read the normal OCT, then you are sure that after cataract surgery your patient is going to do well. Any questions for Dr. Purnima?
So, Dr. Naresh Yadav would now be talking about OCT angiography in common retinal macular diseases.
I'll be speaking on OCT angiography, what all can it show. So basically we know that FFA ICG is the gold standard to visualize and study the retinal and choroidal vasculature, but it has some side effects, and OCTA is the newest tool which gives us equally good information, and it is dye-less, it is quick, has no side effects, and it's repeatable. So basically at each and every visit you can do OCTA. And the other advantage is it gives a 3D, sort of it segments the vasculature. So you can study about the individual vasculature in detail. So the principle is very simple. Basically, if there is a static tissue and if you do repeated OCT scans, all scans are going to look exactly the same. But if the tissue has blood vessels and the RBCs are moving in that, so this will cause a change in the reflectance signal. And this change is known as decorrelation signal. And this OptoView that we have, it uses one algorithm that splits the OCT signal into 4 or more narrower bands, and then you get an average decorrelation, and each narrow spectral band gives independent information on the flow. Sorry. So basically this is the way the vasculature is segmented. So you get 4 layers. One is the superficial capillary plexus, deep capillary plexus, outer retina, and the choroid capillary. Outer retina usually does not have any vasculature. Any vasculature seen there is abnormal. And this is how the printout looks. So you get the 4 slabs, and the OCT also is co-registered. It is besides there. So you can really get a good correlation of the level of the vasculature and what the pathology is there. So it gives both OCT and FFA-like features are both seen. So now I'll go to the uses. Very simple uses I will just tabulate. So you can look at the microaneurysms. So basically FFA is still the gold standard, but OCTA also can pick up to 40 to 50% of the microaneurysms. And the prognostic value is that if you see more microaneurysms in the deep capillary plexus, such patients could have more cystoid type of edema, and these patients could be poor responders also. So OCTA can give you some value regarding the prognosis. The other is, if you look at the FAZ, in the down slides you can see, so the larger the FAZ, the patient is not going to respond very well. The other markers also are there. You can look at the circularity of the FAZ, and larger FAZ could correspond to the drill also. And the other is in the deep capillary plexus. You can see here there's a area of non-perfusion. So such areas usually correspond to the disrupted outer plexiform layer. So if you see the disruption there, these patients also may not do very well with the anti-VEGF injections. The other is, it's very good to pick up new vessels. Sometimes there is always a confusion whether it's a IRMA or a NVE. So OCTA picks up the neovascularization in a very good way, and then it's very good for follow-up also. So you can see here, there's a large exuberant vascular proliferation, small capillaries, and post laser it has sort of come down. Similarly, in AMD also various patterns are recognized. There's a C-fan pattern. It sort of radiates from one side of the lesion, and there's a Medusa pattern. The vessels branch in all directions from the center of the lesion. And here there's no distinct morphology of the membrane, but you see a small capillaries, and this is dead tree trunk pattern. So all these patterns can be picked up on the octa. So basically this is one of our patients. You can see there's a classic CNVM. The OCT shows subretinal fluid with pocket of IRF, and this is the CNVM complex that you see. Could I get this? Sorry for. So you can see how nice the octa shows the C-fan pattern of the vasculature, and this is post anti-VEGF. So you can see the vasculature has come down, the small vessels are less seen, and the OCT also shows there's no edema, and you see a sort of scarring happening. The other useful is in the octa, in PCV. So for BVN it is very good. Almost 85 to 100% of the BVNs can be picked on octa. But polyps sometimes may not be picked up. So that could be because of the less flow, or it could be extraocular in location, or the segmentation is not proper. Because sometimes the polyps could be at the base or at the apex of the PED. If the segmentation is not going through that, you may miss the polyps. This is one of our patients. You can see there's a subretinal polyp here. The ICG shows a bunch of polyps here, and one polyp is seen hyperflow, and this is a hypoflow. So hypoflow polyps are likely to better respond to treatment. So in myopic CNVM also it's very important. 5 to 10% of the patients with pathological myopia can lose vision because of myopic CNVM. And the subretinal heme that you see, it could be because of a new lacquer crack. There could be no CNVM. In that case, injection is not required. Or it could be because of a CNVM formation that you see here. So every time you cannot do FFA. So you can do octa. So here you can see the CNVM complex, and the CFT is increased, and the octa picks up the myopic CNVM in a very good way. So octa is very useful for myopic CNVMs, and when to stop the treatment, that also it can give an idea. So this is the same patient. This is the pre-injection. This is post-injection. You can see the vasculature has come down, and this also some improvement is there. And the patient had a recurrence. So this time FFA was not done. The octa itself shows the pattern of the vasculature has changed, and this is the corresponding OCT. And the other important is patients with chronic CSCR who don't respond, and the fluid remains there for up to 4 to 6 months, and there's a flat irregular PD that is known as FIPED. Such patients also could harbor neovascularization, that is known as pachyneovasculopathy. So the FFA may not give much information, it just shows a hyperfluorescence. But if you do octa, you can see a vasculature here, neovascularization. So such patients respond well to anti-VEGF. So any patient with chronic CSR who has a flat, irregular PD, you should rule out neovascularization, and octa is very useful. For type 1 sub-RP membranes, octa is very useful. So the another use is in MACTEL. So basically in MACTEL, you can see there are just some, if you do FFA, it shows temporal hyperfluorescence, telangiectatic vessels, and if there is a CNVM, sometimes picking up it becomes difficult because there is a hyperfluorescence that the capillaries themselves are leaking. So you cannot make out whether it's leaking from the CNVM. So this is octa. So you just see how much the information you get through the octa. You can see there's a enlarged FAZ, there is a pruning of the vessels, rarefaction of the vessels. So all these features you cannot really appreciate on FFA. So OCTA has given us a lot of clue about the pathophysiology of mactal. The disease usually starts in the deep plexus and then it goes to the superficial plexus. So it has been very useful. So this patient, you can see in both the eyes there is a neovascularization. So this patient will need anti-VEGFs. Similarly, this is the last case, hypertensive choroidopathy. So whenever there is a accelerated hypertension, it can cause changes in the retina, the choroid, and optic neuropathy also. So, and doing FFA in such cases is difficult because already there is a uncontrolled hypertension. So if you do OCTA, and this is the corresponding OCT. So because of the choroidal ischemia, it's going to damage the RP, and then you can get hyperreflective material in the subretinal space. So this is all features of hypertensive choroidopathy, and you can see the OCTA also, how nicely it is showing the flow void areas. So it gives a systemic clue. So because this is going to translate in all the organs, so whatever the microvascular changes are happening in the body can be appreciated by OCTA. And this is a case of CRAO. Our case, you can see there's a sparing of the ciliaretinal artery, and this is the FFA, and we did paracentesis, and then immediately we did OCTA. So you can see the change that has happened. So you cannot really do FFA after paracentesis. So basically, to conclude, OCTA images the retina and the choroidal vasculature in a dye-less manner, but the disadvantages are that a small area is imaged and is difficult in patients with poor vision, learning cost, and availability is an issue. But now we have new machines which give a broader area, larger area, and new machines, prototypes have given us flow speeds also. So this, it will image the flow also. So you will get a fair idea about now it just tells whether there is a RBCs are there or not, but it does not tell about the flow. So the higher flow could be the arteries and lower could be in the veins. So all these things are coming up. So thanks for a patient hearing. I think we have some time. We can take questions or some comments from the audience. Ramesh, you want to add something? You can take the mic. Mic is there.
Sir, in your practice, how useful do you feel the wide field OCT angiography would be useful? Means though we don't have the machine in our setup, how useful would it be in treating many of the diseases, especially proliferative cases, PDRs and vein occlusions? Will it be useful?
I think it's going to be very useful because new studies are showing that the dioptric classification itself could change. And we have also known that the more non-perfusion in the periphery, they're more likely to develop diabetic macular edema and all. So FFA definitely, wide field has a role to play, but OCTA is useful for sub-distinct entities like flat irregular PD, mactal it is very useful, myopic neovasculopathy it's very useful. So our incidence of FFA almost has come down to 50-60%. So if you get a wider area along with the OCTA, and if you can get a relative information about the flow also, so there is a likelihood that the people needing FFA could really come down.
For glaucoma, I wanted to ask Madam that whether GCL would be a better biomarker than the RNFL because RNFL thinning. Can you highlight on that point, ma'am?
So we all know that 50% of our retinal ganglion cells are present in the macula. And therefore, the first changes that take place in glaucoma, the structural changes that take place are in the macula. So if you take the macula and you find whether, in various machines, various types, whether it is the GCC complex or the GCL, almost the same thing, just one of the layers is not taken into consideration. Forget that, doesn't matter. The thing is that that is the first area that is affected. The unfortunate thing is that our OCT information is still not so robust that we will start treating our patient on the OCT findings alone. So we have to take into consideration the clinical findings, the OCT findings. And when you look at the OCT, it is not just the RNFL. Earlier days, it was only the RNFL which was taken into consideration. It is only, let's say, for example, in 2000, maybe 10, 11, that's the decade when Zeiss went into a lot of work, and they discovered that it is the macula, which the GCC, which we have to look into. And that is how the GCC complex and the GCC fundamentals came into consideration. So when we are looking at a particular patient and determining whether the OCT is going to give us information about glaucoma, please let's look at the entire thing, that is the RNFL. But first of all, is it placed correctly or not? That is, the circle is placed correctly or not? The ONH, I've already stated in my entire slides that how the ONH is so important, and various factors like, for example, the rim area, the disc size, so important, and along with that the optic nerve head, the GCC, and the RNFL, all three should be taken into consideration. But to answer your question once again, that is, the GCC is the first part that gets affected in glaucoma.
Thank you.
Madam, any role of Octa in?
Yes, in fact, I was trying a lot of trying to do for glaucoma Octa studies, but unfortunately we didn't have the software in our machine, so we couldn't do it. Octa plays a huge role in glaucoma diagnosis. But the thing is, again, just like we cannot base our diagnosis just on Octa, studies are not robust enough. I think it is in your Narayan Netralaya where Dr. Harsha is doing a lot of phenomenal work on this, and but it is still in a nascent stage. We cannot base our diagnosis on that. There are too many ramifications about glaucoma, whether it is the CCT or it is the optic nerve, the pressures, or whether it is, there are lots of factors. So just taking Octa into consideration and just starting treatment on that would not be still correct. It's information is still not robust.
Dr. Purnima, I had a question in the sense, the artifacts which we come across the OCT, how do you try to avoid them? And would you suggest that doing an OCT in an undilated pupil, especially in a patient who has got media opacity like a cataract, how do you take care of these artifacts?
See, as I said, we always have to correlate clinically. So if we feel the lesion, whatever we are seeing on the OCT is not really correlating, we always repeat it. We have to try and, counsel the patient, like not to have more eye movements, blinking sometimes, they're going to blink. So we have to constantly be at it, like don't move. Like what I do is I keep telling, don't move, don't blink, don't blink. So till it is not taken, I keep telling them. So that's, you have to be constantly at it. And I think with that, most of the patients we are able to manage. Though in some cases where there is more of media opacity, dilated would be better option. Even undilated in a clear media, undilated also, even, you can get very good images. That's not an issue. So in, of course, it's a very dense, cataract or a very thick vitreous hemorrhage, then of course we won't get the images. But majority of the time, even if we get a little outline of the inner retina, so we get an idea whether there is any hemorrhage, there is an edema or not. So sometimes like we have to operate a cataract, but we're not sure what is the status of the macula behind, and especially diabetic patients. So I would like to have a, even if a very hazy image, but that gives me an idea whether we need to inject an anti-VEGF before if there's any edema, or if it is absolutely normal, then fine, we can just go ahead with that.
May I add one thing to this? You asked about the dilated examination and non-dilated examination. So, initially a lot of companies said non-dilated bahut acha image aata hai. But then when we started doing serial, that means the same patient, we suddenly found that RNFL thickness was this much in one particular year, and after that when we repeated it, we found somewhere else it was. So that was not, there was something wrong. So then I started going along and we started doing two things. One is that pay a lot of attention to the segmentation, whether the optic nerve, this ring is present right and around it, it's correctly placed. And third is dilated examination. And the moment we started doing dilated ones, we found that, okay, where we found the RNFL thinning to be present, that came out in the subsequent one also to be. Of course, there are many patients where we can't dilate them, especially people who have been on long-term pilocarpine. We can't help it. If you are under duress, you have to do whatever is available to you. But I find that at least a semi-dilated position of the pupil definitely helps in getting a better image.
OCT which was done on the Cirrus machine, where we had double fovea or a foveal duplication. It was a pseudo image. It was a false image because of the motion artifact. But when you looked at the papers which have already spoken about the foveal duplication or the pseudofoveas, they're all with one specific machine, that is the Cirrus machine. So do you encounter something which is with the Cirrus, or it can happen with any machine? Because when we are using Heidelberg Spectralis in our center, I haven't seen many of those problems. So with motion artifacts, are we saying that the Cirrus is more likely to develop something like that, or the Zeiss machines?
No, I don't think it's machine. I think it is the patient and the person who is doing the imaging. I think it depends totally on them. Once you make them aware, then the thing becomes all right. Cirrus is a fantastic machine, gives very, very good results and very good imaging. There's no doubt about that.
That's what I said. No, counseling is very important. Like I keep telling, don't move, don't blink. So you have to keep at it. So then I think the error is very less.
Madam, my question is regarding epiretinal membranes. So we encounter in all our cataract pre-op screening many patients with ERMs, epiretinal membranes, and then we tell them that your vision might not improve well, and to our surprise, many patients land with 6/9 vision. So how do you predict that this particular ERM will land the patient in bad vision, and this will
See, it depends on the stage. In the early ERM, where there is not much, thickening or much wrinkling of the retinal surface, there we can expect to have a normal cataract surgery and not much progression of the ERM. But where already there is increased macular thickness because of the ERM, then there are chances, we do counsel the patient that this may increase a little post the cataract surgery. So, and of course, where there is marked irregularity, there, of course, then we have to, advise a combined VR surgery with cataract, because there then we have to do membrane peeling. So it's the stage of the ERM, you can judge on the OCT actually. That's why OCT is very important there.
So there a retina specialist will come in play, right?
Yes. So sometimes what happens if it's not too thick a membrane and not too much of irregularity, just there but slightly increased thickness, we may give a preoperative anti-VEGF injection so that it keeps the edema down. It won't increase post the cataract surgery. So many times we do that also.
So basically you have to try to say whether it's a idiopathic ERM or secondary ERM. A lot of secondary ERMs could be associated with BRV or sometimes with diabetic macular edema. In such cases, if there is a ERM with fluid in the macula, such cases you can always attempt anti-VEGF. You give a couple of anti-VEGFs, if they're not responding, then you can say that ERM also is playing a part, and then you can do vitrectomy. But if it's an idiopathic ERM, then most likely you have to remember that you are not treating the OCT, you are treating the patient. So many times you may see that the ERM looks significant, but surprisingly they may have good vision because the photoreceptors are okay. So you don't have to really jump into the surgery. So you can always go ahead with the cataract surgery. If the patient is not responding, then you can say, okay. So, or if you have followed up the patient and you have seen that the ERM is getting worse, the retina is getting lifted more, the vision has come down, then you can go for a combined surgery.
And my next question is to the entire panel. So as cataract surgeons, when I went to the trade, I found out that there are OCTs available from 12 lakhs to more than 1.5 crores. So, I mean, what would the panel recommend that will be a good enough machine for our routine daily practice?
I think any spectral domain OCT should be good enough. You should not go for time domain. A lot of spectral domain OCTs are there. So see, Heidelberg are very costly, but those are the best. But any spectral domain OCT is good enough. Yeah. Any spectral domain, SDOC.
Any spectral domain.
Yeah.
So like there are...
I mentioned this, that you must look at the normative, whatever machine you're buying. Please ensure that the normative data is good. There are lots of machines which are floating around. in which when you ask them that what is the normative data, they have no idea. Then that's of no use. Plus, whether the ethnicities have been covered or not. Let's say an Indian is not covered, then what's the point?
Yeah, basically for the glaucoma part. For the retina part, you will see what is there.
And then there are 30,000 scans and 50,000 scans and 1.5 lakh thousand. Thank you.
I'm sorry, I will not be able to answer this question of yours.
I don't think actually we will get more information from that, because usually the OCT image itself is going to give us a lot of information plus a clinical correlation. I normally don't find any extra information from NFAS OCT. At least I don't know, Doctor.
Some polyps are sometimes seen more on the NFAS OCT and the extent of the. You should be telling us. He's an expert on imaging. Yeah, OCT, yeah.
Can I ask a question?
Yeah, please.
In a patient with wet macular degeneration, sometimes they have vitreomacular traction also, and they respond to treatment, but in the end, they're left with slight fluids. How do you decide whether fluid is due to VMT or wet macular degeneration?
You're saying that whether the fluid is because of the VMT?
Or the wet macular degeneration.
Yeah.
No,
No,
the
many
patient
times.
has responded to treatment.
Yeah. No, many times you need to do FFA. So that could give you some clue whether the membrane is still active or not. So FFA could be one factor. Because many times with patients with CNVM, older patients, vitreomacular adhesion, VMT is quite commonly seen. So I think we take the help of FFA. So
ask one question. Can I ask one question?
yes, sir.
Actually, if the ERM is not thin enough, be it idiopathic or be it secondary to diabetes, should you go for injection even there is some fluid, little bit of fluid? Whether it will work, injection will work, anti-VEGF, I mean.
You're saying if there is a ERM,
Even ERM,
To DME.
it is not thin enough, even in idiopathic or in DME. I have seen that it is not working.
yeah, no, that's what I'm saying, but the patient has come to you for the first time, there is a ERM, there is a diabetic macular edema. So many times you can get an idea that this patient is not going to really work with anti-VEGF, but if any doubt, always give a chance. You can give anti-VEGF, you're not losing anything. You can see the response. If there is no response, suboptimal response, you can always go for ERM surgery.
Should we explain patient beforehand that we can give one injection like that? Or people are now computer savvy and they are knowing that 3 injections are required as a standard practice. So should we inform patient that it is given as a single dose?
For ERM with DME, the loading dose concept is for the CNVM. For most of the time with the ERM, with one injection, you will get a fair idea whether the patient is responding or not. So in such cases, you don't have to wait for 3 injections.
Right.
After 1 injection, you can take a call.
Thank you, sir.
Okay, thanks a lot for attending the CME. We had a lively discussion. I thank all my speakers also, and a big thanks to the audience.